we have a slight change of schedule because Professor Elena Di Mori the Momi has to leave for a flight. So she's Associate Professor of Bioengineering in the Department of Electronics, Information and Bioengineering at the Politecnico di Milano, where back in 2006, she co-founded the Neuroengineering and Medical Robotics Laboratory. And she will talk, as you see, on autonomy in robotic surgery.
Thank you. Thank you for the introduction, and sorry for this change of plans, but I had to go back to Milano. And I would like, first of all, to thank the organizer for inviting me here to this stage, which has been my dream stage since 2009 in my first ICRA in Kobe. And the title of my talk is related to autonomy robotic surgery, which is a hot topic now in robotic surgery. And the subtitle is more related to what I've been concentrating in the last years, so to try to bring research from the laboratory to the clinics. So some words, so just 1 minute about my history in research. So I'm a bioengineer, and I did my PhD not on robotics, but in computer-assisted surgery. So we've been asked by maxillofacial surgery surgeons to provide some hints about having autonomous planning for guiding them during the surgical treatment. And then when I finished my PhD, I decided that I wanted to move on robotics because as bioengineer, I've been always fascinated by the parallelism between the human body and the robots, the brain and artificial intelligence. So I started, I was lucky enough to meet some really smart neurosurgeons and really great guys in Imperial College, and we worked together to designing a new concept for neurosurgery. We wanted to deliver some drugs inside the tumoral tissue within the brain. So we worked together on a steerable catheter for brain neurosurgery, for brain surgery, and our role as Politecnico di Milano was mostly on developing some smart path planning in dynamic environments, because brain is a soft tissue which can undergo deformation while the catheter is advancing toward the tumor. So we managed to get to animal testing. You see also in the previous presentations the importance of testing devices, medical devices in animals, in order to have preclinical testing to prove the effectiveness of the system. But we were missing the last bit. So we were publishing good journals, publishing wonderful research, but we didn't manage to get to the actual technology transfer of our research. So maybe we were not pushing enough, maybe we were doing wrong decisions. So the lesson learned that came from that research is that what is linked now, the research that I'm doing the last years in minimally invasive robotic surgery, so working with general surgeons and urologists, and also developing new catheters for endoluminal applications. So the video that you see here is related to an endoluminal catheters for repairing the mitral valve. So the lesson learned brought me to think that it's important to not just publish on papers, but bring this research to clinics. And to bring research to clinics, we need a lot of work and then we will see in the later slides what are we doing now. And also to have a technology transfer, so to try to transfer all the findings that we had to spin-off companies. So that's the title of my talk, From Bench to Bedside, and what are the ingredients to transfer the research from the lab to the actual surgical theater. So first of all, we had to identify a clinical case together with surgeons. So a clinical case in which could be impossible to demonstrate the effectiveness of our approach versus the standard care. Then we had to finalize our research, our finding in a proof of concept, so that the surgeons could come to our lab and prove the methodology, the research, before transferring to the clinics. In order to introduce technologies, so our framework in the hospital, we had to comply with the workflow that they are currently using. So we have to have a smooth integration in their currently workflow. And last but not least, of course, all the authorization, ethical protocols and authorization from the hospital. So as far as the clinical case is concerned, after a lot of talk with our partners at the European Institute of Oncology in Milano, we ended up in finding radical prostatectomy in prostate cancer, one of the cases which is currently solved mostly using robotic surgery, so using the Da Vinci system in the hospital that we are working with. Why? Because robots have demonstrated to be nerve sparing, vessel sparing, so reducing dramatically the possible side effects of this kind of surgery. So this is the current scenario. So I'm sorry, there are some cruel some images with some blood and some tissue surgeries. So this is the current scenario. So this is the intraoperative view that surgeons have, and this is the preoperative images that they can base their plan upon. So still there are problems. Problems are related to the possibility of cancer recurrence. And the hypothesis that we made together with them is that if it would be possible to better highlight the tumoral margins and also better visualize the metastatic lymph nodes during the operation, the surgery can be safer. So we can reduce the possibility of postoperative recurrence of this kind of tumor. So in the current application, lymph nodes are searched, so radioactive lymph nodes are searched using this detector. And this detector has been integrated in the Da Vinci setup, so these are the current Da Vinci tools. But what happens is that when the lymph nodes are detected, the detector has to be moved, so there is a loss of perception where the lymph nodes actually are. So that's why our framework came into play. So instead of having a visualization with augmented reality, we are proposing to have augmented reality in the surgical field, leveraging on all the techniques that you have seen in the previous talk. So phase recognition, 3D reconstruction using stereo images coming from the endoscope, segmentation of the structures, so the structure that are visible in the endoscopic images, object tracking, because we need to follow the movement of the objects, and finally to have a deformable registration of the preoperative images on top of the intraoperative scene. And these are the results of what we have been to achieve so far. So starting from preoperative images, we segmented the structures and we identified a structure which is also visible during the operation, which can be easily recognized during the operation in the intraoperative images. So that, having also 3D reconstruction, thanks to the stereo images coming from the video stream of the Da Vinci, we can have a 3D reconstruction and we can perform this intraoperative 3D deformable registration, which end up having this augmented reality view of the scene. So also hidden structure can become visible and they follow the motion of the organs while interacting with the surgical instrument. Still, there is some work to be done because when the dissection is performed, these structures should be separated with respect to the vessel. Issues. So you saw also in the previous talk the problems of data collection. In this case, we are not, so the data that we are collecting are coming from the actual operating theater. We can use pre-trained network, but then we need to have fine-tuning on the current procedure that we are approaching. So data have to be collected and also annotated. We have to satisfy the compliance of the data protection regulation in Europe. Annotation entails a lot of work between students and researchers and doctors. We ended up having so speaking with my students, we end up having 20,000 images that we manually annotated. Then comes the clinical study into play. So we need to design a proper study. So study design means to select the type of study, whether it's prospective, whether it's single center, the inclusion-exclusion criteria of patients, the number of subjects that we want to enroll to prove that our method is better than the standard care. And also, most importantly, we need to find the clinical outcome. So what is the real value which can have an impact on the patient health status? And the endpoints that we have agreed upon with the surgeons is to test biochemical recurrence. So that's what we want to decrease when our method is currently into the clinical practice. If this everything works, and if companies or if we are interested in licensing this method, we have to comply with the medical device regulation, which is the new rule that has been applied in Europe, which is kind of slowing down the process because a lot of authorization, a lot of tests are required in order to prove safety and effectiveness of the treatment, but at the same time, a lot of money, a lot of time is required to get it. So where are we with respect to the autonomy classification that has been going on in nowadays, also in order to have a more autonomous system also in surgical robotics. So this classification is motivated by automotive industry, where more and more cars are becoming autonomous. And we are relying on autonomous car because they prove to be safer, so they allow avoiding car accident more often. So the same concept is being applied in surgery, but we are still at the level of providing assistance to the surgeons who can avoid possible errors. So our concept is to have a safer surgery. Then just last 2 bits about my vision and future goals. So this is the vision on robotic surgery, and these are my future goals. So in the short term, I think that the artificial intelligence potential, especially in image processing, can give us a safer diagnosis. Think about all the possibilities given by the image processing in radiology, for example, and safer interventions. In the future, treatment will be less invasive. They'll be based on energy treatments. They could be endoluminal or percutaneous. And this reminds me of the talk of Alison Okamura this morning, so about the possible new concept of interaction between the operator and the robot, which is operating inside the human body. So just a few slides, it's to acknowledge the hard work of all my students. So when I got visited by colleagues, I always receive compliments, not for myself, but from my students. And also when you're having summer school, it's recommended to still have fun with students and not to take yourself too seriously. So thank you for your attention, and I think that also the big impact so far of my research has been also to deliver good students, where I think that now are in most of the laboratories. Ken is getting one of my PhD students, Brad had already one of my PhD students, and I hope that they're doing a good job, and this is so far my impact in this field. Thank you so much for your attention.
So thank you, Elena. We can take quick questions, if you have. Well, I cannot agree more with the gap you have said between the lab, developing prototypes in the lab, and going to real environments. So thanks for doing this transfer, which I think it's very, very important.
Thank you.
Any question? Here?
Yeah.
We have.
There is someone? Yeah.
Hi, great talk. I guess this last slide or one of the last slides about shared control, and I think it's really interesting. Do you think that there's sort of maybe like a rule of thumb of the types of surgeries that maybe could be more relevant for like fully autonomous surgery versus this, these different approaches?
Yeah, thank you so much for this question, because I was really fast on that slide. I think that so when we speak to surgeons, so when we propose to surgeons to be actually guided to do the surgery, they don't want. So they don't want to, and if they don't want, so they want the possibility to override any possible control, because they have to be in charge of the operation. My idea is that providing the assistance as car are preventing accidents to be done, because they can be alerted previously beforehand that our sight, that something is going to happen. In the same way, robots could be stopped, for example, autonomously before hitting a vessel, before hitting a nerve. So I think that it's shared control in the sense that it's just giving the possibility of avoiding mistakes, avoiding unwanted movements, rather than guiding the movement of the surgeon.
So, any other question? No. Thank you very much then.
Thank you.